Hello again, ladies and gentlemen. Welcome to case study number 27. This will be a patient with a witnessed seizure. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I really appreciate all the contributions that you've made to help keep these videos free and coming and offset the cost. And I thank those of you who have already stepped up and donated, and all the rest of you for your consideration. So thank you very much in advance. Alrighty, we got an 18-year-old white man coming into the ED via EMS due to a witnessed apparent seizure. His younger brother says that they were playing video games and suddenly the patient fell out of his chair and onto the ground where he began convulsing. The brother immediately called 911, but within a couple of minutes, the convulsions had stopped and the patient was confused. No medications were administered by EMS and the patient was brought to the hospital. EMS drew a blood glucose on the scene and it was 98 milligrams per deciliter. The brother says that the patient has never had anything like this before and that he does not have any medical problems that he's aware of. There is no history of epilepsy in the family. Patient is a high school student and is not known to drink, smoke, or use recreational drugs. He's on no medications and his vitals are within normal limits. What are we going to do? So his general appearance is somnolent, but he appears comfortable. Head, eyes, ears, nose, throat. Very important to do this. So no evidence of injury. There's a small laceration on the tongue. No signs of elevated intracranial pressure. No meningeal signs. Those are very important things you want to know. Skin, lungs, heart, abdomen, all normal. Neurologically, he's non-focal. That's super important as well. And psychiatrically, he's oriented to person, place, and time, even though he's somnolent. Not unusual. Post-ictal phases after seizures are really the rule. So not uncommon. So what do we find? He's got this laceration, but pertinent negatives, no papilledema, no meningeal signs. So he looks pretty good. Okay, so what is our differential? Number one is an epileptic seizure. Now, can we diagnose epilepsy? No, not yet, and we'll get to why that is. But we have to consider, before we can even try to arrive at the diagnosis of epilepsy, we have to consider precipitating causes of seizures. So first among those, especially in a young man, would be illicit drug effects, particularly stimulants. So cocaine, meth, or even drugs, that he's getting from someone else. So like ADHD meds. So Ritalin, stuff like that can cause seizures. Alcohol withdrawal, syncope. So maybe this wasn't a seizure. He was having convulsions. So, it probably was a seizure, but it could just be regular old loss of consciousness. Space-occupying lesions always need to be considered, and in older people more so, the possibility of a cardioembolic stroke. And then one more thing that I would include in here is metabolic or electrolyte derangements, and that includes hypoglycemia. Okay, so what are we going to do for our workup? Well, your immediate orders, and a lot of times people don't think of this, are that you need to institute seizure precautions. So you need to have soft padding on his hospital bed. You need to make sure that there's an IV saline lock. Typically EMS will have done this. You need to make sure that's there though, because if he does go on to have another seizure while he's at the hospital, you do not want to have to run an IV while he's convulsing. It's a lot easier to just do that while he's not having a seizure, okay? So we're going to get a CBC looking for the possibility of infection. We're going to get a BMP looking for hyponatremia, electrolyte causes. We're going to get, in addition, a serum calcium, phosphate, and magnesium. That doesn't come on your BMP, so you'll need to order that separately. We will get an EKG, and then importantly, this urine toxicology screen. Now, the brother says that he doesn't abuse drugs, but you know what? Who tells their little brother that kind of stuff, right? So you got to check anyway. So we find that the CBC, BMP, and calcium phosphate magnesium are all within normal limits. The EKG showed normal sinus rhythm, and the tox screen showed cannabinoids. Now, does weed cause seizures? In very high doses, some people say it can, but generally no. So this is probably just a kid that does weed, has nothing to do with this. You see it all the time. So the presumptive diagnosis is an epileptic seizure. In particular, this is a tonic-clonic seizure, generalized. You need to admit this patient. You're going to consult neurology for evaluation and likely ongoing management. When you follow this patient up, you need to, and that'll probably be with neurology, but you need to know that this has to be done. You're going to counsel the patient and the family, particularly if the patient lives with family. The patient needs to abstain from alcohol. Why? Well, alcohol does raise your seizure threshold, but when you're withdrawing, and I'm talking immediate withdrawal, so the kind of withdrawal we all go through, like hangover, your seizure threshold is greatly reduced. So it's very important that they abstain from alcohol, at most 1 or 2 drinks, and then do not drive. Other orders would include an electroencephalogram, also known as an EEG. Typically, the neurologist that's consulting will order this, but it is important in CCS that you know that this needs to be done. So seizure is a neurologic event that's due to abnormal neuronal discharge manifesting in abnormal motor or behavioral changes. Now, that sounds like a really vague definition, and it should be because not all seizures are tonic-clonic like this patient's. Seizures are a symptom, not a diagnosis, so you need to exclude conditions that precipitate seizures, as we did. And only after doing this can you settle on a diagnosis of epilepsy. However, epilepsy needs to be more than one seizure. You need to exclude head injury or mass infection like encephalitis or meningitis, hypoglycemia. Think of type 1 diabetics that may have taken too much insulin, electrolyte derangements, specifically hypoglycemia and hyponatremia, and then substance abuse or withdrawal. There are a lot of different types of seizures. You need to be familiar with them. I'm not going to go into each and every one of these, but I put this on here so you know. The big thing, though, that you need to draw from this is status epilepticus. That's a seizure that lasts longer than 5 minutes, or multiple discrete seizures within 5 minutes. This is a medical emergency, and you need to know how to manage it. So to manage status epilepticus, first immediately when you get on the scene, you need to ensure your ABCs. Don't ever stick anything in their mouth. Gently turn them on to their left side to avoid aspiration. You want to check a blood glucose right away because that can be easily fixed. If their blood glucose is less than 60, infuse them with thiamine and D50. You also want to obtain IV access for reasons that were already mentioned. At 5 minutes, you're technically in status epilepticus, so you will administer an IV benzodiazepine, and we go with one of these short-acting ones. Now, a lot of physicians will just go ahead and give benzodiazepines right away. That's not technically what you're supposed to do, but you see it done. At 10 minutes, you will repeat the same benzodiazepine. At 20 minutes, then you can give them levetiracetam or phosphonatoin through the IV. And then at 30 minutes, you would consider induction of coma with general anesthesia and rapid sequence intubation. We're thinking here like propofol. Now, phenobarbital used to be on the recommendations, and there's a variety of recommendations from different sources, so you may see phenobarbital, but this was the source that I got my information from, which is from a journal that specializes in seizures. So as long as you kind of know this stuff, you're pretty much good to go. Some common differentials: illicit drug effects, look for that urine drug screen. Alcohol withdrawal, typically a history of alcohol abuse. They don't need to be an alcoholic. Just one big episode of binge drinking can precipitate a seizure the next morning, but typically these patients are alcoholics. Syncope, look for a loss of consciousness, but convulsions are uncommon, and generally there won't be that kind of confusion afterwards. In younger people, there's often a trigger, so they see blood or something like that. They get that vasovagal syncope. Space-occupying lesions typically come complete with focal signs, and the CT will tip that off. Cardioembolic stroke, usually in older people. Other things, metabolic disturbances, we would find that on our electrolytes, CNS infections, he would have meningeal signs, prolonged confusion, fever, white count, so forth. So to recap, a seizure is a neurologic event due to abnormal neuronal discharge manifesting in abnormal motor or behavioral changes. You need to exclude common causes, and epilepsy is 2 or more unexplained or unprovoked seizures. CT is essential in anyone who has had a first seizure or who has signs of head injury or focal signs, and typically we will get CT just all the time in the ER because we often don't know these patients. We don't know if they've had a seizure before, and it's easy to do. Status epilepticus is a seizure that lasts more than 5 minutes. First step is to ensure an adequate airway, make sure they're not hypoglycemic, and give IV benzodiazepines. In patients who are known to have epilepsy and are on medications, check their drug levels. Subtherapeutic drug levels are one of the more common causes of seizures in people who already have epilepsy. So you don't need to go through a whole diagnostic battery for these people, but make sure you get their drug levels, so their phenytoin levels or their Keppra levels or whatever. Typically, neurologists will not start long-term anti-epileptic therapy until there's been more than one seizure event, i.e. they have epilepsy. So on CCS, don't worry about, starting Tegretol or starting Keppra or starting Depakote. You don't need to worry about that and your multiple choice questions that may come up. But as far as CCS goes, you're really triaging these patients, making sure there's no precipitating cause, getting them off to neurology for their EEG and for their management.